In this presentation, a 4-part fracture of the proximal humerus will be treated with the Epoca shoulder arthroplasty system. Please refer to the official technique guide for the list of indications and contraindications. After viewing this presentation, you will understand the surgical approach and the correct preparation of the humerus, and the correct application of the prosthesis. The preoperative radiographic assessment is completed with standard AP, lateral, and axillary views. Additionally, a CT scan is strongly recommended. An AP view of the contralateral humerus is optional. However, it is helpful to estimate the size of the prosthetic head and stem. The patient is placed in a beach chair position. Hyperextension and lateral inclination of the cervical spine away from the operation side should be avoided to prevent tension on the brachial plexus. The patient's arm should be freely draped for full mobility at the shoulder. It is important to plan the placement of the C-arm so that adequate images can be obtained if needed. The incision is started over the coracoid process and extended 8 cm inferior over the anterior deltoid lateral to the deltopectoral groove. Alternatively, the Langer skin tension lines can be followed starting from the acromioclavicular joint. The fascia is opened over the deltopectoral groove and the cephalic vein is identified. The deltoid is retracted with the cephalic vein situated laterally and the pectoralis major medially. The clavipectoral fascia is incised. This is the 4-part fracture. The anterior fragment typically consists of the lesser tuberosity, the bicipital groove, and a small part of the greater tuberosity. The posterior fragment consists of a large part of the greater tuberosity. There is often a split in the substance of the supraspinatus tendon. Stay sutures are passed through the subscapularis, the supraspinatus, and the infraspinatus tendon. To preserve the thin periosteum, take care that the greater tuberosity is not grasped with clamps or pulled anteriorly when passing the sutures. The biceps tendon is cut at the insertion of the pectoralis major. In a clinical situation, the biceps tendon would be attached to the pectoralis major with sutures. The supraspinatus split is extended as required to expose and retrieve the humeral head. As a rule, the rotator interval does not need to be opened. The sutures are gently retracted to expose the humeral head. To retrieve the humeral head, the posterior medial periosteal sleeve must sometimes be incised. The humeral head is retrieved and should be saved for later use as a humeral height indicator and as a source for bone graft. By gently pulling on the dorsal and ventral stay sutures, the glenoid can be inspected to see if it is still intact. Since the anteroposterior and the mediolateral diameters of the humeral head differ by a mean value of 6 mm, an intermediate-sized spherical head is chosen. In the clinical setting, a sliding caliper may be used to exactly measure the head size. The trial head that most closely matches the retrieved head is chosen. To prepare the tuberosities for later fixation, a humeral stem, a 2 mm drill bit, a 14G catheter, and 2 1 mm diameter cables with crimp are needed. In the clinic, the biceps tendon is divided and prepared for later tenodesis at the level of the pectoralis major muscle. The tuberosities are inspected carefully at the tendon insertion. If any cartilage is still attached, remove it. 2 2 mm holes are drilled in the greater tuberosity. The holes should be aligned with the medial and lateral holes of the prosthetic stem. The first hole should be drilled close to the point of transition from the tendon to the bone. A catheter is passed through the hole as an aid in inserting the cable. A 1 mm diameter cable is inserted through the catheter. The catheter is removed and the cable is parked posteriorly so that it does not interfere with the rest of the procedure. The second cable is inserted approximately 2 cm superior to the first, in the same manner. The shaft is exposed by extending, adducting, and externally rotating the humerus. To prepare the medullary canal and determine the retrotorsion, a cylindrical rasp, a sharp curette, a size 6 and a size 8 rasp, a 6 mm retrotorsion bar, and a goniometer are needed. In the clinical situation, if the canal is not open, the cylindrical rasp is used. A size 6 rasp is inserted into the canal with gentle taps of the hammer. Because of the ellipsoid shape of the proximal humerus and the calcar design of the Epoca stem, the stem tends to be seated in the correct rotational alignment. In the clinical setting, the rotational alignment is checked by first inserting the 6 mm retrotorsion bar into the threaded hole of the rasp. The goniometer is clipped onto the lateral side of the retrotorsion bar. For the initial adjustment, the rasp is aligned to 25 degrees retrotorsion with reference to the axis of the forearm. This angle reflects a median retrotorsion value. The retrotorsion is confirmed by cross-checking against the bicipital groove. The distance between the deepest point in the bicipital groove and the center of the rasp should be approximately 8 mm. The posteromedial metaphyseal extension H is measured on the retrieved humeral head and noted. This distance determines how much the stem must protrude above the medial fracture line. The rasp is hammered in until the correct prosthetic height H, as measured previously, is obtained. If the rasp penetrates too far into the medullary cavity, it is removed and the next larger rasp size, here size 8, is used until the correct seating is obtained. If the rasp cannot be fully inserted, it is withdrawn and additional bone is removed along the medial endosteal region using a sharp curette. This will allow the rasp to be seated a few millimeters deeper. The pronounced calcar design provides the rasp and the implants with self-centering, self-rotating, and self-locking capabilities. In the clinical setting, care must be taken when hammering to avoid producing a cortical split. When the correct depth is reached, the rasp is removed. For the insertion of the trial implants, a trial stem, the inserter extractor, the combined hammer, a trial eccenter, a trial head, and a 2 mm and a 2.5 mm hex screwdriver are needed. The inserter extractor is attached to the selected trial stem, here size 8, which is inserted into the canal with controlled light hammer blows applied to the top of the inserter extractor. Hammering is continued until the trial stem protrudes above the shaft by the previously measured posteromedial metaphyseal extension H. The inserter extractor is removed. The trial eccenter is attached to the trial stem using the 2 mm hex screwdriver. The letter A on the trial eccenter is aligned with the lateral line on the trial stem. This position reflects the median offset in a fracture situation, when it is not possible to predetermine the humeral head offsets, as in the intact proximal humerus during arthroplasty or degenerative conditions. The 2 mm hex screwdriver is used to back out the set screws from the trial head to allow correct seating. Care must be taken not to back out the set screws too far, as they may fall out. The trial head is mounted on the trial eccenter. In the clinical situation, the trial implants are often assembled before insertion. The appropriate marking on the trial head is aligned with the center line on the trial stem. In general, this marking is 11 for the right humerus and 1 for the left humerus. The trial head is locked in position by tightening the anterior set screw and the center screw with the 2 mm hex screwdriver. The trial implant is ideally positioned when the gap between the trial head and the humerus is equal to the previously measured posteromedial metaphyseal extension H. There should be neither an overhang nor a medial step-off between the medial calcar line of the humeral shaft and the trial head. If the offset is not appropriate, the antero-posterior position and/or the mediolateral offset have to be adjusted. The trial eccenter is loosened with the 2 mm hex screwdriver. The 2.5 mm hex screwdriver is used to rotate the trial eccenter until the desired position of the head is achieved. Note, the 2 mm hex screwdriver is used for locking and unlocking the set screws and the trial eccenter. The 2.5 mm hex screwdriver is used only to rotate the trial eccenter. For further adjustment, the anterior set screw on the trial head is loosened with the 2 mm hex screwdriver, and the trial head is manually rotated until the desired position is achieved. The position is locked by tightening the set screw. Once the offset position of the trial head is recorded, the trial head is removed using the 2 mm hex screwdriver. If there is difficulty reading the offsets in situ, the complete trial prosthesis should be removed intact and the offsets checked. It is important that the offset number, in this case 11, and the offset letter A are noted, as these will be used to assemble the prosthesis. The inserter extractor is mounted on the trial stem. To avoid possible damage to the thread, it must be ensured that the inserter extractor is fully threaded into the trial stem. With light taps against the inserter extractor, the trial stem can be backed out. To assemble the prosthesis, a humeral stem, a stem holder, an eccenter impactor, and a head are needed, along with a press and a torque wrench. The eccenter is positioned on the stem. The offset letter A that was noted during the trial implantation is aligned with the center line of the stem. The eccenter has to sit flush on the stem. The stem holder, corresponding to the size of the shaft, is chosen. This assembly allows the stem to be firmly held in the press. It is important that the etched side of the stem holder is facing up. Improper assembly may cause jamming. The eccenter impactor is mounted on the eccenter. The assembly is placed in the press. Using the torque wrench, the handle of the press is turned clockwise in a controlled slow motion until a click is heard, signifying the positive engagement of the eccenter and the stem. The torque wrench is turned anti-clockwise and the assembly is removed from the press. The eccenter impactor and the stem holder are removed. The head is placed on the stem assembly. The offset number 11 is aligned with the center line etched on the upper surface of the stem and with the offset letter A. The offset can still be adjusted by rotating the head. The stem holder is remounted. The assembly is placed in the press. By turning the torque wrench clockwise, the components are compressed until a click is heard. The torque wrench is turned anti-clockwise and the prosthesis is removed from the press. The stem holder is removed and the prosthesis is checked for an adequate seating of the head and the eccenter. There must be no visible gap between the base of the head and the stem. The alignment between the head and the stem is also checked. The prosthesis is introduced into the medullary canal. The head impactor is placed on the head, and with light taps with the hammer, the prosthesis is fully seated. This position must correspond to the predetermined anatomical prosthetic height h. With the humeral head still anteriorly dislocated, the cables that were initially placed through the greater tuberosity, rotator cuff junction, are passed through the medial and lateral perforations of the stem. A 2 mm hole is drilled in the lesser tuberosity. The hole should be approximately aligned with the lateral hole of the prosthetic stem. A catheter is passed through the hole. The lateral cable is passed partway through the catheter. The catheter is then retracted, bringing the cable with it. This process is repeated for the medial cable. The prosthetic head is reduced to the glenoid. Using cancellous bone graft harvested from the retrieved head, any void under the tuberosities is filled. The fragments are reduced to the prosthesis. The absorbable sutures are used for preliminary reduction and adaptation of the relevant fragments. Over-reduction of the greater tuberosity has to be avoided, especially in the distal direction. The most medial insertion line of the supraspinatus must be flush with the edge of the prosthetic head, not distal to it. Sutures are used to close the supraspinatus split. The tuberosities are embraced and compressed to the rectangular cross-section of the shaft to obtain rotational stability. To crimp and trim the cables, the crimping pliers, the wire tightener, and the cutting pliers are needed. The ends of the medial cable are passed through the crimp. The cable is tensioned by hand, but not over-tightened. The crimping pliers are applied to the crimp. The wire tightener is mounted to either side of the crimping pliers. The nut on the wire tightener is opened, and the cable ends are passed around the nut, which is then tightened to hold the cable in place. The cable is tensioned by squeezing the handles of the wire tightener. To prevent deformation of the tuberosities, the cable should not be over-tensioned. The cable is crimped by compressing the handles of the pliers. The pliers and the tightener are now removed. The cutting pliers are used to trim the cable close to the crimp. This procedure is repeated for the second cable. The joint of the bone model can be opened to check the fit of the prosthesis against the bone. From this presentation, you should now understand the surgical approach and the correct preparation of the humerus, and the correct application of the prosthesis in a fracture situation.